displaced and living in refugee camps. She was deeply moved by their resilience in the face of adversity and knew that she wanted to devote her career to helping them. In 2019, she joined Medglobal as a clinical coordinator at the world's largest refugee camp in Bangladesh. As a technical advisor to doctors, nurses, and midwives of Medglobal's health facilities in Bangladesh, she was responsible for ensuring that their healthcare services were of the highest quality possible. During her time at Medglobal, she received training on the Mental Health Gap Action Program by WHO, which consists of interventions for the prevention and management of priority conditions such as depression, schizophrenia, suicide, epilepsy, and dementia. The training allowed her to provide critical care mental health support for those who needed it most. In addition to her work with refugees, she's also worked as a research assistant for non-communicable diseases at the Center for Injury Prevention and Research in Bangladesh. Throughout her career, she's developed special interests in chronic diseases, women's health, and pediatrics. She's a firm believer that mental strength is just as important as physical strength and always strives to provide compassionate care to her patients. As a Bangladeshi physician, she's committed to using her skills and expertise to help those who need it most. Next, we have Dr. Helal Mohiuddin. His research interests and specialization are, he is a professor of political science and sociology at the North Shore University in Bangladesh and a research fellow with St. Paul's College of the University of Manitoba. He is the project director of the Rotary Global Grants supported Rohingya female adolescents non-formal education pilot project in Bangladesh. He is a Winnipeg resident. He also serves as the director of research and communication with the Conflict and Resilience Research Institute in Canada. He obtained his PhD in anthropology from the University of Manitoba in Canada, his MS in regional planning from the Asian Institute of Technology in Thailand, and a BS and MS in sociology from the University of Dhaka in Bangladesh. Throughout his research and teaching career, he's held a number of positions over this 30-year career. His research interests and specialization are globalization-led changes in social dynamics, livelihood strategies, indigenous knowledge systems, gender and development, disaster preparedness, participatory development, qualitative research, and social and political movements. As a researcher, he's worked with UNICEF, United Nations Development Program, UN Women, UN Volunteers, CARE, BRAC, Action Aid, World Vision, Concern Worldwide, and Human Development Research Center. He is one of the founders of the Conflict and Resilience Research Institute in Canada, and he's co-authored and co-edited 7 books and published 35 articles and book chapters in reputable national and international journals. He has contributed to 40 social research projects as a principal investigator, a co-investigator, or a team member. We are very excited for their presentation today. Please join me in welcoming them. And thank you, and let's go ahead and get started. Dr. Parvin, you are going to go first, so please feel free to share your screen. Or Jeannie's going to share it. Great.
Assalamu alaikum and good noon, everyone. Thanks, James, for sharing the screen. Actually, in today's presentations, the topic is mental health issues among the Rohingya population in Bangladesh. As a physician, I will share my clinical experience through this colloquium. So let's start. Next slide, please. Thank you. Am I audible to all?
Yes, we can hear you just fine. Thank you.
Okay, thank you. Okay, so from the beginning, I want to share the Rohingya conflict. What is the Rohingya community? Who is the Rohingya? So the Rohingya conflict in Myanmar has its roots in the country's complex history of ethnic and religious tensions. The Rohingya are a predominantly Muslim ethnic minority group who have lived in the western state of Rakhine, formerly known as Arakan, for centuries. In 1982, Myanmar government passed a citizenship law that effectively rendered the Rohingya stateless. denying them access to basic rights and services, including education and healthcare. The government has also restricted their freedom or movement and denied them the right to vote. Over the year, tensions between the Rohingya and the Buddhist majority in Rakhine have escalated, with outbreaks of violence and discrimination against the Rohingya becoming increasingly frequent. In 2012, a wave of violence led to the displacement over 1 lakh Rohingya, and since then, the conflict has only worsened. In 2017, a military crackdown in response to attacks by Rohingya militants led to a mass exodus to over 1,200,000 Rohingya to neighboring Bangladesh, where they now live in refugee camps. The military action have been widely condemned by the international community as ethnic cleansing and genocide. Today, the Rohingya remain one of the most persecuted minority group in the world, with little hope for a resolution to their plight in the near future. Humanitarian emergency in Bangladesh. The Rohingya crisis in Bangladesh has been an ongoing humanitarian emergency with hundreds of thousands of refugees fleeing violence and discrimination in Myanmar, along with the challenges of accessing basic needs such as food, water, and shelter. And Rohingya refugees also face significant mental health issues due to the traumatic experiences they have faced. In this presentation, we will discuss the mental health issues among the Rohingya population in Bangladesh, our clinical experience working with them, and recommendation for addressing their critical issue. Mental health issue among the Rohingya population. The Rohingya refugee face significant mental health challenges, including depression, anxiety, post-traumatic stress disorder, and suicidal ideation. Many of them have experienced several trauma, including witnessing the murder of family members, sexual violence, and torture. The ongoing uncertainty of the future, with no clear pathway to citizenship or to return to Myanmar, exacerbated their mental health issues. Moreover, the cultural stigma associated with mental health issues, coupled with the lack of access of mental health care, adds to the burden. Common mental health conditions among the Rohingya population in Bangladesh. In this manner, many patients complaints of like nightmares or flashback, aggressiveness, suicidal tendency, delusion, and substance addiction are also common. There are symptoms of trauma and unresolved grief. When the conflict began in 2017, the first time when Rohingya entered into the Bangladesh, this is not the first time, this is the time where huge amount of Rohingya community peoples comes to the Bangladesh. In that time, the most commonest mental health condition is flashback, which is, we say, post-traumatic stress disorder, and nightmare also. But after passing so many years, like 4 to 5 years later, this also still going on. The common mental health condition where the Rohingya population comes to our facility or comes to any physician or mental health personals, like depression, anxiety, I already said that, post-traumatic stress disorder, grief, bipolar disorder, schizophrenia, psychosis, psychological difficulties, which is linked to epilepsy, which go virtually unnoticed by their community. Patients with visible sign of psychological distress are said to be possessed or under the influence of black magic or jinn. The Rohingya community, excluded from healthcare for decades in Myanmar, often resort to traditional healer due to ethical, cultural affinity and patients' beliefs and lacks of trust in healthcare provider in the camp, because actually they are not exposed to hospital or clinic in Myanmar due to military restrictions. Patients' isolation and loneliness is another challenges for mental health teams. Their inability to contact their family in Cox's Bazar or Myanmar due to restriction on movement or telecommunication can worsen existing condition. Here is some risk factor who is behind the story of the bad mental health will be being older, being female, persons living with disability, exposure to often multiple potentiality, traumatic event, experience, threat of human rights violation, lack of space, like they are living in a very congested space, one household for each family, but they are belongs like 6 to 8 family member in a family, so they are extended family, and they are living in a small room. For this living condition, their mental health is very poor, and also for this condition, some skin condition and other physical condition also increasing day by day. Sexual and gender-based violence also a risk factor for it, breakdown in social moral, loss of identity and exclusion, child separated from parents, separation from community members, lack of food security, being unable to work, pursue a vocation or further education, poverty, lack of access of services, lack of freedom of movement, lack of activities, stimulation, and support in camp. Next slide, please. Okay. Medglobal activities. Actually, Medglobal working in world largest Rohingya refugee camp, which is in Bangladesh, Cox's Bazar, since 2017, and Medglobal serving the healthcare, every services into the Rohingya community and also serving the host community. In case Medglobal is non-profit organization that provides both medical and mental health services to refugees, providing Rohingya refugees since 2018. We have trained a local staff and volunteers to provide counseling, therapy, medication management to refugees. We have also established a referral system for several cases that require specialist care. Many patients are referred to mental health counselor only when they come to seek medical treatment for any physical condition in our health facilities. We also work for strengthening mental health awareness activities among the community through doing the awareness session like door-to-door visit and check the community person and asking them about the health issue and screening them about the mental health condition. Like if our community health worker goes community door to door and asking if some family member ill, either physically or mentally, but in the Rohingya community, they are not recognized actually the mental illness. Maximum Rohingya population understand that mental illness like insaneness or some other things is the issue of hideness. They hide that issue. If someone exposure did, then they are dominated into the community. That's why they are hiding this issue. So our CSW goes to door and to identify if any health issue or any mental health concern there or not, and refer them to the health facility. And after coming our facility, we identify the survivor or client if any mental health intervention is needed or not. If needed, physiological first aid we provided the counseling, we provided the cognitive behavioral therapy, and after that if the patient need any psychiatrist intervention like supervision, some other specialized, then we refer that patient. Okay, next slide please. Yes, the past year Medglobal activities like counseling, sessions, staff capacity build up, and we seen total 914 cases where male is 372 and female is 542. Next slide. Case study. Yeah. Actually, the prevalence of chronic psychosis, a severe mental disorder that requires psychotropical treatment, is also high among Rohingya patients. Like when 70-year-old Rohingya boy named Janel, it's actually not his name, I hide that name, first came to our facility, he behaved like children and was disconnected from reality. This organized thinking, seeing or hearing something that are not present, and behavior like the exhibited by him, it's typical sign of psychosis, which need a long duration of session counseling and also medical intervention. I have a success story that in my clinical experience, have observed it like 25 years old Rohingya woman who had fled from Myanmar with her family and was living in a refugee camp, Camp 24 in Bangladesh, came to our health facility with the complaint that depressed mood, flashback, nightmare, loss of interest in pleasurable activities, loss of appetite, decreased body weight, crying, hypersomnia, recurrent thought of death. This was the mental and physical problem she had been having for the past 2 years. After hearing her complaints, took sessions and took time to explore her, and she was diagnosed as moderate to severe emotional disorder. After several counseling, I able to develop a trust-based relationship. As I mentioned before, they are actually not believe in any kind of medical modern treatment just because of they are not exposed this kind of treatment in Myanmar. As they have a restricted movement in Myanmar, they are not able to go in a government hospital or clinic in Myanmar. So they are believe in like both the herbal healer or the shop in the medicine shop where the medicine is delivered. They believe that persons that if they go to that persons, they will be cured. So in that case, this lady, 25 years old Rohingya lady who came to the Myanmar in Bangladesh, have been suffering this kind of condition for like past 2 or 3 years. So when I first talked to this lady, she was not able to expose her or any kind of personal issue or any kind of mental sickness. She is just complaining that she's suffering from this kind of thing. She thinks that when she slept, she see the firing, the exhausted movement or army military movement. And I speak and take several sessions. I was need much time to handle this client actually. So in that case, after several counseling, I able to develop a trust health relationship, and she started to open up about her trauma. She had witnessed the murder of her husband actually and was raped during the journey to Bangladesh. Cognitive behavior therapy was used for her management. As I said before, this is mostly useful thing that we can do in this setup, but we need much time. Keep the patient, giving the patient much time for this kind of evaluation actually, which is very time consuming matter and very difficult to maintain to such an area. But this client wants to recover and go back to normal life. As a result, after completing the psychology course, she released. After more than 4.5 months of session, she felt healthy. At the end of the session, she came to the clinic and said that she was feeling better with the psychosocial treatment. She was advised to follow up treatment and follow up when she will feel any mental or physical problem. This is very, I think, a successful story for us that a woman who was suffering so many kind of mental trauma, and after exploring her sadness and after advising something, not advising any kind of medicine, and after giving a huge time of these patients and after giving some therapy, the patient is cured, totally cured. So I think this is a success story for us, and I believe a gift is this is a gift from the patient. Patient smile is the best gift for any kind of physician or in that case any counselor. Next slide, please. Scope of work. Constant stress of living condition and of the uncertainty to their future is taking its toll due to re-traumatization. In addition, the stigma that accompanies depression, anxiety, and other mental health disorders make it challenging to provide adequate treatment as well. That stigma is not just within the Rohingya community, but within the host community as well, along with a shortage of mental health providers. This is vicious cycle. To address this mental health issue among the Rohingya population in Bangladesh, there need to be a multifaceted approach. The scope for work should be building awareness and reducing the cultural stigma around mental health issues, training local staff and volunteers in mental health care to provide the counseling therapy, providing medication management for patients with several mental health issues, establishing a referral system for several cases that require specialist care, conducting research to understand the mental health need of the Rohingya population, and developing evidence-based intervention. Next slide, please. Challenges. Actually, in working with Rohingya community in a camp setup, there are lots of challenges that we faced every day. The challenges we can mitigate, but in that case, we need a huge intervention. We need a focus on this mental health crisis. I would say it's a crisis. We need to focus on this. The challenges is addressing mental health issue among the Rohingya population are huge. One of the biggest challenges has been the lack of awareness and understanding of mental health issues in the community. Challenges are also included lack of resource, cultural stigma, and shortage of mental health professionals. Moreover, the ongoing political tension within the Myanmar insurgency and the lack of a clear pathway to return exacerbate the mental health issue among the Rohingya population. They are thinking about some oldest person, mostly Rohingya wants to go back their motherland. And some group of people thinking that actually where they are now and when they will go back. So this kind of thinking exacerbates the mental health condition. Additionally, there is a shortage of mental health professionals in the area, which make it difficult to provide care to everyone who needs it. Actually, in that case, in camp setup, there are limited access of psychiatrist intervention. In case of any kind of severe mental health condition, it's very difficult to cure. Next slide, please. Recommendation. To address this challenge, we recommending increasing the research, training, fellowship opportunities for mental health professionals working with the Rohingya population. It is also important to design the mental health and psychosocial support interventions that build on the strength and resilience to the refugees. This may include involving community members in the design and implementation of intervention, working with traditional leaders and religious leaders to raise awareness about mental health issues. Just because of the Rohingya community, actually they obey any command of their traditional healers. So if we involve this kind of community masters to awareness session or some other major issue, we can get a good feedback. Moreover, there should be a coordinated effort among national organization or international organization and government of Bangladesh to address the mental health needs of the Rohingya population. Next slide. In conclusion, mental health issues among the Rohingya population in Bangladesh are a significant concern that required urgent attention. Medglobal is committed to addressing this issue through our mental health program and by advocating for increasing research and training opportunity. We believe that with the right interventions, we can improve the mental health and well-being of the Rohingya refugees and help them to build a brighter future for themselves and their families. Providing health care is not just providing care for physical health, but all should include mental health. The two are intimately connected. Thank you all for hearing this and seeing my presentation.
Wonderful. Thank you very much, Dr. Parvin. All right, on to our second presenter. Please go ahead and share your screen.
Good afternoon, everyone. This is night in Bangladesh at this moment. It's about 11:30, I believe. Anyway, thank you very much, Alison, for your generous introduction of me. Do you see my slides? And am I audible properly?
We do now. Thank you.
Right.
We do see it.
Okay. So let's get to the main point. My focus was adolescent mental health for different reasons, as Dr. Rahana Parvin has already mentioned about the background and conditions that are prevailing in the refugee camps. There are gulf of problems. We can't just solve them overnight or outright. That's why when I was engaged in different types of projects there, we tried to make a baseline study at the same time, the root cause analysis about the mental health situation there. Why we did that? Because we had an education program, and in implementing that education program, we noticed that we need to address mental health problems first, because it was the biggest challenge appearing at that time. So that's why we started to focus on something different, and gradually we started to focus more on this topic. So what happened, we did actually considerable amount of research that have taken place in different Rohingya camps all over the refugee camps all over the world, as well as Rohingya camps in Bangladesh. Still now, there are different studies going on. Most of them are clinical studies. The biggest problem is that mostly they are disjointed, and the psychosocial component are mostly missing. There is a dedicated sector by the government. It's a subsector known as mental health and psychosocial support, but we have seen many challenges, many loopholes in that sector's implementation process and activities. There are reasons, because the camps operate, all the programs of NGOs or other implementers run only up to 3:30 to 4 p.m. every day. So after the afternoon till the next morning becomes something else. The camps become controlled by goons, hooligans, drug dealers, other people, terrorists, and radicalized people. It becomes a completely different world. And it is really difficult to manage two worlds at the same time using only one model. So there we did in-depth research, and it is our finding that adolescents are the most vulnerable among all the Rohingya refugees there. The reason probably is simple. We haven't really dig very deep into that, but it is our sense that the adult people, they have been living in Myanmar under extreme and harsh livelihood conditions under the British military rulers since 1962. And that's how they might have developed their resiliency. This is why they are coping up quite better here as well. They are recovering their trauma mostly by themselves without any help from others, outsiders. most of the time, in most cases. But for adolescents, when they came here in 2017, probably they were 5, 6, 7 years old child, and now they are becoming the teenagers. And during this time, they have all the harrowing and the horrific experiences, traumatic experiences that they can still remember. And since the adolescents are the most unattended segment of Rohingya population, by different interventions, even international organizations are not really paying much attention to that. I must say here that there are expansive programs, gender-based programs for the adolescent female girls, but not for boys. I don't know why. And we asked this question to the camp administrators, and they could not really provide us any good or satisfactory answers. So adolescents are mostly neglected, and among the adolescents, male adolescents are even more neglected. There are health and hygiene programs for the adolescents, girls, menstrual hygiene maintenance, and psychosocial mental health and psychosocial support programs are embedded in those projects. To some extent, it's not now that discussable whether they are working well or not. We may discuss that a little later when in the question and answer session. But the point is that they are better off in terms of service reception. So they are the better target group because all of the programs have gender component embedded in that, and menstrual hygiene is one of the biggest part. So adolescent girls are better off in that sense, but the boys, they have enough time to wander around, to get involved in antisocial activities, to become radicalized, and whatnot, everything. So they are peddling drug, they are consumers as well. They are getting involved in whatever sort of income generating activities they get on their way without having any kind of value system working on them, because as you understand, it's the refugee camp, and there is really no one to take care of them. And their parents, it's less identified at this moment who are their real parent, because sometimes they are living with someone else, maybe their uncle, their community members, their parents who are dead, killed during the Exodus period. So the family composition is somewhat complicated there. It's not that blood-related family most of the time. Many times, although that they are living with their families, but some other time, there are many adolescents who are living in different sort of arrangements with community members of their neighbors, those who are their neighbors back home in Myanmar. So adolescents are most vulnerable, and they're the riskiest groups. They're the riskiest group, the camps. And there are different institutional mental health and psychosocial supports, but these support systems clash with their cultural interpretation, as Dr. Rahana Parvin was mentioning before, that they depend mostly on indigenous healers, community elders, and most of the time on superstitious beliefs. There are reasons too. We'll be discussing that a little later, why they depend mostly on them rather than formal medical support systems that are in place there by different NGOs. So the indigenous knowledge system, the idea is also misunderstood and misapplied there. Many NGOs are working there. Sometimes they confuse with the indigenous knowledge system and the superstitious healing system that are in place there. Sometimes it's being misapplied as well. They understood, they got some training from some organizations or UN organizations that you need to respect the indigenous healing system of these people, but they are not really sure whether the healing system, healing mechanisms that are in place in the camps are really indigenous medicinal system or indigenous healing system, or these are something else imposed by some, money-making petty interest groups in the camps, and other people who are just trying to appropriate their helplessness in this disparate situation. So these are the real problems there. And emergence of idle brain is devil's workshop. And this idle brain, we just introduced this term, the idle brain business networks, because it's really complicated. There are different groups that are emerging almost on an everyday basis just to exploit these helpless people and their, idle situation. Since they are not allowed by the government to get into any kind of livelihood activities or income generating activities, they have enough time in hand to get involved in anything that comes through their way. And this is why there are different rackets and groups, criminal organizations are emerging just to take advantage of their, joblessness situation. And so we termed it just idle brain business networks in a meeting. One of our colleagues just introduced the term. And a divide and rule politics is becoming intensified almost every day. There are reasons too, just to get benefit and to take advantage of these people. So many studies are still taking place there, but only a few of them are balanced, taking into consideration the social and cultural realities of these people. Some are highly critical, highly technical, and highly, scientific, like quality of life studies. There are a number of studies I am familiar with. And these studies were challenged at some point by our team members that, okay, quality of life is a qualitative indicator, and you made it too mechanized, quantified almost everything with some clinical jargons and some technical terms that are not even understandable to people, how you are really utilizing these indicators in the field to get information and then analyzing them. It was a big question to us, and we are not convinced so far, because we have seen many loopholes there that people are not really connected. They became habituated to meet outsiders. They know what to say. Sometimes when we start asking them a question, they keep answering because they know what we'll be asking later. Because of the NGOs, 136 NGOs are working there, and they have expansive programs. And on top of that, there are UN organizations, UNHCR, World Food Programs, and other programs. So they became kind of trained in managing other people. And as in the methodology, we call it Hawthorne effect. They first read us, try to read us, and try to appease us, try to satisfy us. And they remain prepared for that. It becomes a big problem there because they create fictitious stories, fantasize stories, make some stories that are overly made up and far from the realities, but some people are taking them as for granted, like case studies. So information is turning into disinformation, misinformation, and malinformation. We try to focus on these problems as well. So stigma and cultural interpretation of mental health, it's one of the biggest things. They, as Dr. Rahana Parvin also mentioned, they try to hide everything and try to point their fingers to others that, oh, you have mental health problems, but I'm fine. And it is taking place almost everywhere. And it is creating a conflict among them, between them. There are many incidents also recorded by our team that people want to hide everything because they know that they are being outcast by getting exposed of their health problems, especially mental health problems. But we see almost every day that the people are not right. Mental health situation is really deteriorating every day. The locked-in socialization, this term we introduced to this because these people are completely excluded from mainstream society. And for some strange reasons, the government adopted a policy not to let them go outside to study in local languages using local curriculum, Bangladesh curriculum, Bengali language curriculum. So they are taking education using Myanmar curriculum. The government is thinking that these people are staying here for temporarily only and they will go back at some point. But this is a daydreaming, I must say. They are not really relocating to their, motherland very soon because of the diplomatic loopholes and hangouts. It's not going to take place very soon. So these people are in a kind of locked-in socialization context that is not neither desired, not regular or normal, and things are changing almost every day, and you cannot keep track of anything, what they're doing, what they're going, what is their perception at this moment, what they feel, what is their desire, their future plan. NGOs are saying them something, they're saying yes, 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 and yes, because they know that it will give them some reward, they will get relief and other benefits. These are the main attraction to them. Because of those attractions, they are trying to accommodate them in a very abnormal way, like just the benefit recipient mindedness has become common. And this is why, as I mentioned before, that adolescents are left out. They are not being taken care of by anyone because it's not the duty of the NGOs, and the parents are thinking that no, we are not in a settled situation since we are displaced. We don't have a country, we are stateless, we can move anywhere, anytime. It is not my duty to take care of that. And other people, they also blame the other people, that other people caused us this trouble. So it is their responsibility and they'll take care of our kids as well. So that's really putting the adolescents in the biggest danger, and they are the victim of this locked-in socialization situation, becoming desperate. Most of them are depending on informal agencies like rumors, gossips that are not true. They are listening to the modern, as Dr. Rahana Parvin mentioned before, that conscientization sessions, awareness building sessions, everything is there actually, and in advanced forms. But the thing is that these service recipients are all the time very positive about these services, that these services are giving this a special benefit. In reality, they are not trusting these benefits. They know that these benefits might go away anytime, and these are just temporary. Sometimes they don't even believe that these are true, that these people are making some money out of some projects, and this is why it is their duty. They are doing their part, we'll be doing our part in our own ways. So misinformation and disinformation, malinformation, all these things are bad. They're completely depending on all those things. And this is why it became even bigger problem to make any proper record of their, mental health conditions. And then this is the psychosocial, mental health and psychosocial support pyramid. There are specialized services focused on specialized supports as well. Strengthening community and family support schemes are being implemented by different NGOs there too. And social considerations in basic services and security, this idea is very common, almost embedded in all of the projects of different NGOs, projects and interventions of different NGOs. But what we get next? The early childhood trauma is mostly neglected because they have seen that trauma before coming here, as I mentioned before. All the NGOs are starting from now, like the project is starting from 2023, and they are taking this demographic into consideration. This person is 11-year-old, this service recipient or potential service recipient is 13 years old, from today, not from 5 years back. But their childhood trauma is still with them, and it is really shaping up their mentality. So far, we noticed it needs to be taken seriously care of. Then the flight family members, especially seniors, the caretakers, breadwinners, they have a tendency to flee, to leave their family members unattended. They don't want to take responsibility, and it is putting women in danger, especially women-headed households are increasing. Then when women-headed households are increasing and women themselves are also suffering from different types of mental health problems, child growth, as you know, childbirth is unbelievably high. The rate of childbirth is unbelievably high in these camps. And they are taking care of them. They cannot take care of the adolescents or others, or senior members, or the dependent ones, or those who are physically disabled, looking for or needing special care. They can, and this is why. So extramarital relationship, and then elopement, and other sort of adjustments. These are just livelihood strategies for these people, but these are causing huge mental health challenges in the camps. Their poor language skills is another problem. Then cognitive and behavioral factors. This one I can't just explain right away. There are something that we need to discuss maybe later. Then psychological resilience, that we say there is really no project about resilience to make these people resilient. So all the projects are just temporary, time bound, 1 year project, 2 year project, and once projects are gone, these people are put back to the same status where they were at the very beginning. And these camp dwellers also saying all the time to us that, look, we can't trust any one of you because you are coming and then you are counting your time. 1 year project is over, you are leaving us unattended, and then we are back to the same situation that we were in 1 year back. And then caregiver mental health is another problem. Those who are supposed to provide them the mental health there, they also need some mental health support. They are also suffering from the challenge because, it is an estranged community. They are living separately outside their family and support networks. At the same time, it has only limited time. After that time, they don't have enough, scope for socializing or leisure or having some fun and pastime around. It is a distant, remote community, and they are providing the service there. So they themselves are not really mental health fit in this context. So these are the problems that we have identified, and out of that we have some ideas that what to do. We have done extensive literature reviews and found that there are different types of interventions all over the world in refugee camps, especially different refugee camps in the world. And some of them are working well, like individual interventions, narrative exposure therapy, family interventions, group-based interventions. But these things work mostly in those camps that are 20, 25, 30 years old camps, not the newer ones. Like in Bangladesh, there is one registered camp, a very old camp, and in that camp, most of the activities really work very well because these are settled. Then none of these intervention models are ever replicated in the camps in Bangladesh, and there is no interest of the NGOs to replicate or to try or to pilot whether they work there better or not. And teaching recovery techniques, this is another model that we have seen all over the world in different refugee camps. And it is our understanding that we might do a pilot there with this one. It might work in Bangladesh. Cognitive behavioral therapy program in improving post-traumatic stress, depressive symptoms. And in Gaza, and in Lebanon, this model was, so far we know, and we have the information practiced in those camps, and Indonesia and Burundi, probably it will work in Bangladesh. We have none really tried. So we are proposing to start a pilot project there maybe starting with TRT model. And we have some considerations: physical, mental, physical order, or transdiagnostic. Model should be introduced where there will be some social and judicial factors embedded in as well, because there are legal issues, lot of legal issues that are remaining completely unattended, like a divorce, a separation, fleeing. Everything is being managed by just shalish, informal mediation process by the elders or community leaders. Government can't really impose any kind of legal options on these incidents and events. So everything is once again becoming informal, and the informal arrangements are never sustainable. These deeds are being broken within a month, within a week, within a day, even a day, and this is creating the chaos, and mental problems are really becoming staggering in different parts of the Rohingya camps. So we propose to integrate them, and probably we need to develop a model that will be very simple, understandable to people-centered, and the service recipient centered, so they can participatory. In a word, participatory thing at small level, small scale. We can pilot for a year, and then we may get a better idea. Then the last thing is pandemic, pre-pandemic, and post-pandemic situation, of course. These ones are important. Before the pandemic stage, we had a model, something like this model: mental health, the stressors. What are the stressors? We could identify easily, but after the pandemic, post-pandemic situation and in pandemic situation, it became much more complicated, because government was not really, it was well managed in the camp. I must admit that the pandemic did not really hit hard the refugee camp dwellers, and it was well managed. But the thing was that these communities were really in big shock and apprehension, in huge tension that probably we are going to die. But nothing happened there. Yeah, that's a good sign. But nothing happened because this did not have enough communication with the outsiders. They were living in a kind of enclave, and in a segregated, in a secluded area. That is why probably they were much better safe than the other people in the host communities outside the camp. So the last one, very last time I'm just talking about the studies, especially UNHCR. It kept studying the mental health situation in the camps from the day one, from 2017 when the crisis began. From that time onward, it really kept maintaining this research still now. But still there is, the biggest problem is about disjointment and non-participatory focus. It has a strong clinical focus, medical focus, and institutional focus, like NGOs will do everything. Participatory approach is very missing there for unknown reason. I don't know why. In other countries, normally UNHCR prefer participatory model, that people should take care of themselves and they might be given some ownership so that they feel a strong sense of belongingness, that we are here, we are solving our problems. We are trying to develop, from the Conflict and Resilience Research Institute Canada, we are trying to develop a resilience model that will be completely participatory, but that will have a 50-50 focus, 50% clinical focus, and 50% psychosocial, social, and cultural ingredients in that. And we will be targeting mostly on the adolescents only, not other communities, because it was very clear to us. We identified it without any doubt that these are the biggest risk group in the community, especially in the camp situation. So adolescents will be given the attention in our future programming, future model. So these are the cultural influence, like they have a strong belief in spirit possession. not mental health. They don't admit that these are mental health problems, that we are fine. These are just spirit possession, ghost possession, and we know how to heal these problems. They do something that are anti-scientific, pseudoscientific, and most of the time black magics and other sort of alternative arrangements are heavily being utilized in the healing process. Fictionization, as I mentioned before, that it's part of their survival strategy. They make a lot of stories that are not really true. And if you can identify, detect which ones are true and which ones are false, then that's a big problem. So resilience matters. There are different misattempts, drug abuse, desperate moves, all these problems are there, and we already. These are some of the technical things I don't need to share here because we are running out of our time, and you are all familiar with all these things. The causes that are really exacerbating this mental health problem in the refugee camps, they are not pretty different, completely different from other contexts. And these ones are specifically drawn out of the experiences from different refugee communities all over the world. So they have some basis. And Dr. Rahana Parvin also mentioned those things before. I see here, you see that is factors and protective factors, UNHCR, as well as different NGOs. And we also detected the same thing. But these are not the solutions. These are the same thing, just we are talking about the same thing again and again, and we need to move from that kind of entrapment of remaining in the same cycle and rotating in a vicious cycle. Here we have some insights that will really help us. Adolescent boys and adolescent girls, what are their problems and how we need to take care of them. So these are being listed out these days, and probably that would be very helpful for us in the near future if we go to introduce any project. My point is that we have done the baseline work and the root cause analysis. Now the thing is that we need a serious academic research, especially at pilot level. We can pilot there something on adolescents, not all groups at this stage, because this is one of the most dire needs. Parents, as well as other community members, whenever we approach them, okay, what kind of mental health intervention do you really prefer at this moment? All of them pointed their finger to the adolescents that, look, we need to keep our kids live a good life and not to get derailed and completely to dogs, but we don't see any future of them. If you can do something, please try to do something for them. So that's the main inspiration for us. And this is why we are planning to do something. And if anyway we can get any support from University of Illinois, Chicago, probably that would be one of the best things, because at NGO level, they have little interest in academic research. They think that no, applied research is more important since we are going to launch some interventions, and we will be going to apply some remedial models, healing models. It needs to be not just fact finding or problem finding, but solution focused. But without finding the problems, if diagnosis is not proper, I don't know how we are really that confident to introduce different healing mechanisms and models. And this is why I think Dr. Rahana Parvin will also agree with me that it is very disjointed. And whatever they are doing around a lot of stress and some kind of formal structural arrangements, not with in-depth focus, in-depth understanding, and dedication and conviction. So these things are very much lacking there. But then the last thing that I need to say at the very last word, we also spoke to the adolescents. In a number of sessions, we arranged about 10 different sessions with the adolescents, and their perception is the same, like their parents and others, that look, we need to live a good life. The way we are here is we are getting completely wasted and we don't have any future. And every day we are feeling like committing suicide, doing something bad, because that will give me some sort of pleasure. So like joining gangs, trading drugs, they clearly mentioned all these things. That look, we are getting all these negative, impulses because these things are giving us at least some pleasure, and we are thinking that we are living, we are lived animals here. Otherwise, we don't see our existence. This is a kind of psychological existential crisis there in the camps. So we need to focus on the adolescents. Thank you very much. And I would be very pleased to respond to any of the questions that come from the audiences today. Thank you.
Wonderful. Thanks to both of you for this very informative presentation. I invite the audience to please submit questions into the chat. You're also able to just raise your hand and we can unmute you and you can ask your question directly. There is a question from the audience, so I'm going to just, I'll mention it now. And, there was some discussion about the people receiving misinformation. And so the question is, in what forms does the spread of their misinformation and gossiping occur? Is it person to person or technological?
Thank you. It's not technological, it's person to person, very interpersonal, and it spreads very fast through personal communication network because they live in a ghetto sort of arrangements and live very close by. So one person to another person, it spreads, rumors spreads in 10 minutes, in 15 minutes to the whole community. It doesn't take time. They don't have access to internet because it's restricted and it has limited use only among the workers only there and staffs, government staffs and NGO staffs for limited time. So these people don't really get any sort of formal network to spread any kind of information. And this is why the rumor is leading there, and misinformation and disinformation are becoming part of their everyday life.
Dr. Parvin, did you want to add anything?
Yes, I want to add something that as the living condition is much congested, so the household is like one house, and besides another house, there is gap is so much limited. So their living condition also congested, and they are interlinking. Like internal communication skill is very high. So if like one person one-to-one health facilities and he or she takes a good take care about him or her in health facility, take any kind of physical intervention, he or she goes back to his house and spread that words that I goes to his this kind of health facilities, I take this services and I feel good. So after the next morning or 1 or 2 morning, I found out lots of patients from same community, like same household or around same household. So in that manner, the rumor, the bad thing also spread same manner. Yeah.
Thank you. You guys had mentioned that one of the biggest challenges is the lack of awareness of mental health issues. And then Dr. Parvin, you had mentioned that Medglobal has been providing some mental health awareness campaigns. And the question is just how receptive has the community been to these mental health awareness campaigns?
Actually, we have a mental health and psychosocial support team. We had a psychology technical person and 4 psychosocial support volunteers. They actually goes back to door and make the awareness session and take the ill patient or physically or mentally sent back or referred to our facility. But due to the funding intervention and due to the funding limitation, our this mental health team is now reduced. So this is the challenges for us. Now we are 3 physicians who is learned or trained about the image gap, who is what is the training is mental health gap. That training is provided by WHO. This is the basic trainings and this is the basic skills that WHO provided us to learn on humanitarian setup. So we are now doing that. If we found any kind of patient who need the mental health support, we at first give the psychological first aid, provide the counseling, take the session, and after that, if it's not curable or if it's not improving, the patient is like the previous condition, we need to refer. But here is also one more thing, the referral procedure is not so good because like each camp here is 34 camps and 2 registered camps. So if each camps or 1 or 2 camps have one psychiatrist, who can provide any kind of severe mental health condition treatment and also other therapy. So in that case, the distance between the health facility is very far. So referral condition is not so good. So, but if the patient intervention is needed, then we have nothing to do. We need to refer the patient. Yeah.
Good. There's a question, along the lines of there being a shortage of mental health professionals. If there's been any effort to collaborate with local university students being trained to become mental health professionals to provide mental health treatment for the Rohingya population.
So, Dr. Rahana Parvin, you will be answering to that, or should I?
Yes, you can answer it.
Okay, that's a very good point, Alison. And we have been talking about that again and again, that why not the university psychology students and clinical psychologists, they can do their internship there. But none of them are really interested. We tried to say before, they are not interested for the funding system is not that great in Bangladesh. If they live there, they will have to live on their own, and there is no established organizations that they can claim that we have done our internship or the lab works under them, and it is credible enough to get the credits. So university students are not really finding it attractive or lucrative in that sense. At the same time, it's very challenging. It's not easy to live in a camp situation. And no one has the ability in Bangladesh, being a poor members of the poor country, citizens of the poor country, they can't really afford on their own. They need some kind of support. At the same time, we need really trained students, not everyone. They need to get proper training before entering into the camps. So sociology, social, cultural, awareness trainings and other trainings are needed as well, alongside the psychiatric issue handling expertise. So these are the situations. But anyway, now there is a big gap. Now students are not working. Only I know the some university, maybe someone from Johns Hopkins Universities once I met, that he was there, but he was not a regular, researcher. He just went for 3 or 4, 5 days just to get a sense of the camp situation, something like that. And later I tried to contact or know something about that student, and I got the information from the camp administration that no, they haven't seen that person any longer. From that time onward, this camp administration is overly bureaucratic, and this is another discouraging factor for most of the foreign students or local students. They have to fill out many forms, different types of forms and undertakings, and then their safety, security, because the camp administration is overly cautious that they might get into trouble when they allow some outsiders. Information might get leaked. These people might become, these people might serve the, information leaking agencies for some other countries. So there are a lot of suspicions. People don't trust in each other, and this is why it is becoming difficult. But for research institutes and organizations, it's quite easy. We know some of them, some of the organizations that are working there, because they have established footing and background is quite strong. This is why these organizations are being allowed the camps to work, and we might utilize them easily. They can bring students, they can find some students there that will probably help better. Like Dr. Rahana Parvin said, like they had one psychiatrist, right? One psychiatrist in previously, but she left because the project funding cut or something like that. And interest also matters. Probably she was not well paid, and she was not feeling it any worth to stay there. Right? Am I right, Dr. Parvin? Something like that. So all of the projects are suffering from this kind of leakages. And yeah, I don't see really any dedicated program, although this is a specific subsector, MPHSS, right? Mental health, MH, PSS, mental health and psychosocial support by UNHCR, World Health Organization, and then the camp administration, RRC, all of them own and belong to this subsector. But this subsector is one of the weakest subsectors, actually, I would say. Like education sector is very strong there. Then protective security is doing, I believe, quite good. But this sector, mental health and psychosocial support sector, are too half-hearted and too disjointed. There is no integration between different organizations. It's my observation. I might be wrong. Dr. Hannah Parvin might correct me in that sense because she's living in the camp for long time, continuously without any break.
We are just over time. Dr. Parvin, if you want to respond to that, and then I just wanted to end on one last question.
I just want to add one thing that actually, sorry, speaking right, this is the essential, one of essential needed into the camp setup besides the health services, because without mental well-being, healthy mental well-being, health will be not properly cued. So besides any kind of physical health services, we also need the mental health intervention. But in camp setups, lots of organizations working with mental health, but it's kind of short project or something's short-time duration project like 6 months or 1 year, not the sustainable something like but the patient who is suffering from mental illness, she or he will be need continuous counseling, because when she will be skip the session or skip the counseling, the mental intervention or mental illness will becomes again. So we need this program sustainable, not the short period or something else. Yeah.
Thank you. And
I just need to add a last insight. We have seen that there are different self-help groups and volunteering schemes. These ones are working really well. And this is why we are confident that at least we can develop a resilience project, especially participatory resilience. They will take care of their own problems. After 4 o'clock, there is no one actually to go to. There is only 2 or 3 specialized service centers where they can go in emergency situation. But if they can develop different cooperatives, self-help cooperatives, and it's connected with different, psychosocial support providing institutions or organizations for 24/7, that would really solve the problem a lot, because they really need to hear something. I have seen that even speaking to them heals them a lot. Just talking, playing with them, spending some time with them, and just having chat and fun, playing Ludo, all other activities. These, interactions make them feel so comfortable, and they ask for these things, that we are ourselves within the community, within the family, we are becoming disjointed because there are people who are trying to keep us separated, divide and rule. There are different, terrorist organizations emerging these days, and they want to keep people divided, separated into different groups for leadership, for drug and arms dealing, other purposes. So there is a tendency, but these people often say that we need to stay together, and you can help us to stay together if you just teach us how to stay together, how to use our time best. Give us some of the tools so that we can utilize our time in the most entertaining and enjoyable manner. We will remain together, we'll be fine, we'll be able to take care of ourselves. We don't need really external, outside interventions or help too much. We can help ourselves. We are very confident. So that's the insight that probably we can think about to develop something in the future.
Thank you. So we do have to wrap up. We're about 7 minutes over time, but I think this was a good question to end on. So it said, how can a Bangladeshi medical resident, but I think this is relevant for all students here, who is interested in the work that you are each doing, get involved with your work. So for example, get involved in educational, like research type work, as well as the work done by Medglobal.
At this stage, I think we need action research. Research is the most important thing. We need to do that. And if it is participatory research, then a student can get benefited doing research at the same time, doing something for healing. Just some kind of piloting. So action research projects are working pretty well in other sectors there. And in this sector as well, mental health sector as well, students can join in action research programs. They can prepare a master's, practicum. At the same time, support people there just to form their cooperative, to take care of themselves, and what are the considerations, what are the things that they need to really pay attention to. So they can train, they can be trainer. At the same time, they can be researcher. They can be part of it, they can be healer too.
Mm-hmm.
Maybe. So these are the things we have been thinking over the years out of our experience in the camps. Thank you.
Mr. Parvin?
Yes, he or she, the student or researcher who wants to come to the Bangladesh to do something, so he can connect it with Medglobal, and the next procedure will be done by Medglobal. So please, if you're interested to do something, you can connect with Medglobal.
Mm-hmm. Wonderful. Thank you very much to both of you. I know it's very late at night. You are 11 hours ahead, I believe. So really, really, really appreciate you taking the time to speak with us. I think this has been a tremendously informative event, and the recording is, has been a recorded lecture. And so this will get posted on our school's websites for people to review it at a later time. Again, thank you very much. We really appreciate you taking the time to speak with us.
It was a great pleasure.
Mm-hmm.
Great pleasure. Thank you. Have a good day.
Take care. Bye-bye.
Take care. Bye.